Good afternoon. It's a pleasure to be here. Thank you all for coming out to this beautiful room on a beautiful day. How lucky are we that it's not raining yet? Let's see what we got here. Okay, great. So over the next 40 minutes, I'm going to talk a little bit about precision medicine for rare and common ovarian cancers. But just as a way of background and an outline, I'll talk a little bit about cancer genomics in general, and then tell you about a rare tumor that I usually leave to the end and run out of time. So lately I've been trying to promote this rare tumor story because it's a model of what we're really trying to do with precision medicine as a whole. And then a brief update on ovarian cancer, possibly redundant with what you might have heard this morning, but I don't think so. And then a little bit of update on the genomic landscape and where we're going with regular common ovarian cancer. So why do we study genomics and why is precision medicine important? It's important because we're only getting so far with surgery, chemotherapy, and radiation therapy, although not so much radiation therapy for ovarian cancer. However, we want to keep in mind that these modalities work very well. We do cure some patients with advanced ovarian cancer, and we now can have many patients live for a very long time with good quality of life because of these modalities. So they work very well. They work much better than they used to work. Over the past 3 decades, the outcomes are at least 30% better. So we are making improvements, but they're slow, and we certainly have to do a lot better. However, these modalities don't work so well for everyone. And just like precision medicine, it doesn't work very well for everyone, at least today, but for some people, it really works great. And that's why I call it a marriage, because what we want to do is marry the right person to the right drug. And that's really where the benefit of precision medicine can come in. Because as of now, we pick a drug not based on shooting a dart at a dartboard, as a lot of people might say. We actually pick a drug with a lot of thought based on what treatments someone's already had, what toxicities might have developed, what schedule is appropriate, and we have a lot of input. But sometimes it does come down at the end of the day to decide between 1 or 2 drugs, and we may not have a scientific reason to pick one or the other, and that's why I call it like dating. When you're trying to find a mate, you date with a few people, and then one finally clicks. We don't really want to do that with treatments. We want to marry the treatment to the right person. And so what else genomics can do is predict things. It can predict who might live longer, who might not live longer, who might have an earlier recurrence, who might not have an earlier recurrence. And that's nice, but it's not so useful because we really have to make a difference and change the natural path of the disease. But knowing, that may be the first step, putting people into groups, who's going to do better, who's going to do worse, and we can stratify people. But what we'd like to do is stratify patients for treatment and figure out who's going to respond to this class of medications and class of drugs. And on the scientific side of things, if 5 or 10 years before we get into clinical trials is really understanding the biology, because most drugs develop out of an understanding of biology, although a fair handful of drugs develop by accident or luck, and certainly there's nothing wrong with that. So one of the ways we've approached cancer genomics over the past decade is by having large collaborative groups work together. Because about 10 plus years ago, the NCI, in their infinite wisdom, actually realized that no one can do this alone. And we need to bring teams together, and team science is actually synergistic, where the sum of the parts is bigger than the whole. And so that's where some of these research consortiums have come along. And this is just a map showing the Cancer Genome Atlas, TCGA Research Network, which is a large network around the country of doctors, of scientists, of pathologists, of computational biologists, of bioinformaticians and IT personnel. And really the first question 10 years ago is, can these people who would never come in contact with each other actually work together? And there were a lot of skeptics, but it's a little bit like Field of Dreams. If you build it, they will come. And in fact, the NCI built this network, and nowadays people think it was well worth the initial $100 million investment that grew to about $500 million, because we learned a lot about cancer genomics and cancers in general. And just like sequencing the human genome was the roadmap to understanding human disease, these cancer genomic studies is essentially the roadmap to understanding various cancers. And now it's our obligation to take that information and turn it into therapeutic opportunities for people all over the world. So one of the things that was a big strength about cancer genomics, and one of the things that's very important to do from the beginning, is to start with high quality material. And one of the reasons why this project was believable is because all of the work was done in a very rigorous manner, including reviewing all the pathology material, making sure that things like DNA and RNA were very high quality, and all of it was deposited publicly. So all of the research community could access the data. And in fact, the data was put into forms that both the very sophisticated computational biologists could understand, but also the simple doctor could also go on and ask simple questions that this complex data could be interpreted for both sophisticated and less sophisticated scientists and doctors to understand. Not that doctors are simple, but when it comes to this high sequencing data, it's very complicated. Myself, I'm in the middle. I understand some of the really complicated stuff. I understand most of the simple stuff, but there are very complicated things that require, cloud computing just to, do these sorts of analysis. In fact, I was working with some folks at Hopkins, and we had to analyze a project, and they told me that if they did it on their own computer cluster at Hopkins, which is not a bad place, it would take them about 3 weeks to do the analysis. They put it in the cloud. I think it was the IBM cloud. I'm not sure. It was done in 3 hours because they could actually put it up in the cloud and access hundreds of servers just for a short amount of time, and that analysis can be distributed. And even though Hopkins, like NYU and other places, have large computing clusters, it's still not like what you can do when you kind of borrow basically servers from other people. Just as an example for the whole project, these, let's see, does this mouse work? Can you see the mouse? Yeah, okay. So these little codes here are various tumor types, and if you count them, there's probably about 20 to 30 different tumor types. And overall, the project itself received more than received almost 20,000 cases, which you can see up here in the corner, and after extreme quality control, only 11,000 cases were distributed, and so there was a very rapid fall off to get rid of things that didn't meet high quality standards. And so that's kind of the background of what cancer genomics looks like in 2016. And the interesting thing is that once you publish, once the group and other people publish comprehensive, integrated, and high quality data, you learn a lot about each individual disease. And here I've put the ovarian cancer paper in larger font because it's one of my favorites. But you can see a handful of about half of the tumors that were published in high quality journals. But the interesting thing is that after you learn a lot about single cancers, the next thing you can do is put them all together and just learn about cancer in general. And that's one of the strengths of these types of approaches that are coordinated by a single institution or single organization like the National Cancer Institute. And so what we did in the beginning, I didn't do much of this myself actually, what they did in the beginning is take the first 12 cancers that were analyzed and they integrated them. And you can see that over here is just a representation of the different types of analyses that were performed on each cancer. And you can put them together into these networks, which is somewhat useful and somewhat just confusing. But after that, you can actually learn about the features of cancers in general. And that's what I'll show you on this next slide here. And I'll draw your attention to this graph, which is something that we call a parabolic graph, which means it looks like this type of curve. And basically, there are some tumors that are driven by mutations. And so that's a defect in the DNA, which is basically the instructions on how to make proteins. And there's some tumors where the DNA has gone awry, and where it's supposed to make one type of protein, it doesn't make that protein properly because the DNA has been damaged. And how these mutations develop is a number of different mechanisms, including when you go outside into the sun and get a suntan, you actually are introducing a lot of DNA mutations. The remarkable thing is that our body has redundant mechanisms to repair these DNA mutations all the time. We have multiple DNA mutations occurring in our bodies every time cells divide, and almost all the time they're fixed. It's remarkable that babies come out as healthy as they normally do, and it's remarkable that most of us don't get more cancers and don't get cancers at a younger age, although of course some people do, but it's remarkable how much repair the body can do. But sometimes it doesn't, and sometimes that turns into a cancer, and some cancers are driven by these DNA mutations. And that's sort of what's demonstrated with this part of the curve over here. On the other hand, some cancers are driven by having too much or too little of the DNA. And what happens there is the chromosome where the DNA sort of resides, the chromosome can get duplicated or triplicated or quadruplicated or even more, or deleted. And so therefore a whole gene or an important part of a gene will get lost or gained. And those are called copy number alterations because the number of copies of the gene has changed. We're supposed to have 2 copies of every gene. I think we all know where we get one from one person and one from another person called our parents. And that affects our whole body. But in the cancers, or when the cancer is developing, or when it's growing and spreading, those copies can get amplified or deleted. And that's called copy number alterations. And what we learned is that some tumors, specifically ovarian cancer, are driven mostly by copy number alterations. If you look across the whole human genome in an ovarian cancer, you'll see that there's lots of copies of genes that shouldn't be there, and there's a number of genes that are missing that should be there. And those are called copy number alterations driving basically high-grade serous ovarian cancer. Now, it turns out in ovarian cancer, there's actually one mutation in a gene called P53 that's very important, and that one mutation actually leads to all the copy number changes. But essentially, ovarian cancer is a disease driven by copy number alterations. You may be familiar with endometrial cancer from the uterus, which is right next to the ovaries. Endometrial cancer is predominantly a mutational driven tumor. Most endometrial cancers don't have a lot of copy number alterations, but they have a lot of mutations in very important genes. My laboratory in particular studies those 2 diseases, and it's a nice contrast because we have one cancer driven by this and one cancer driven by this other mechanism. So I just want to kind of explain that we can see all that very clearly from doing all these genomic studies and putting them all together. So just to summarize the introduction and maybe one message is that molecular profiling for high-grade serous carcinoma may be very beneficial when we have clinical trials that we can use for targeted agents, or if we have good reason to do what's called off-label use. However, you have to think about it very carefully. And if you have children, you may be familiar with the person on the left who's Fancy Nancy, and she loves to live at the Ritz, and she's very, fancy and special, whatever. And if you're from New York, or if you follow NBA basketball, on the right you know is Jeremy Lin, and he was very hot a few years ago. We used to say, people used to talk about Linsanity. And the real question is molecular profiling fancy science of precision medicine, or is it expensive hype? And we don't want to confuse the two, okay? Jeremy Lin, expensive hype. He's done okay, but not like he did when he was playing with the Knicks. I'm not a big basketball fan, Knicks. Or Fancy Nancy, so is it just all show? And we don't know, but I will tell you there are a lot of companies, and your doctors may be saying we should profile your tumors, and that may be great. And I love profiling tumors because I learned something scientifically. I don't love profiling tumors because it usually doesn't help the individual patient today. But I'm hopeful and enthusiastic it will help many patients with ovarian cancer in the future. In other diseases, it's become a little more useful because they're mutationally driven diseases, and we can find the mutations in the DNA, and we have some good drugs that are working. In ovarian cancer, we don't have a lot of mutations, and a lot of the molecular profiling looks for DNA mutations, and we don't have a lot in high-grade serous ovarian cancer, and so it doesn't often help the individual patient, but sometimes it will. And you could make a personal decision whether it's worth doing it, whether it's worth potential confusion, whether it's worth the expense to somebody, whether you're paying for it individually or our healthcare system's paying for it. But it's a sort of a controversial issue as to whether we should be doing it. I do send it on many of my patients because every so often we might find something that might help somebody. But as of today, for high-grade serous ovarian cancer, it doesn't often help the individual patient. It does help our research, it does help our future. It's good to generate that data, so that's a little bit of a proper balance. But the companies, they're making money, and they're making a lot of money off the stuff. And it's very good stuff. It's cool, I love it, but they're making a lot of money. And so you really want to say, how is this test the right test, and is it useful for me? There are at least a dozen plus companies doing these tests. There are a small number doing them well and doing them reasonably and giving information that's useful and with the appropriate caveats. There's other companies that may or may not be on this slide that will often give you results that do not come from good scientific rigor. They might find a mutation that was shown to be effective for someone who had lung cancer, and I might send it on a patient of mine who has ovarian cancer, and they'll say, well, we found this defect, and you should give this drug because it worked in lung cancer. But most of us are smart enough now to know that that means nothing. Something that works in lung cancer may or may not work in ovarian cancer, and we have to study that not really at the individual patient level, but in the context of a clinical trial. On the other hand, there's, at NYU, we got a dozen plus excellent clinical trials, other places in the city, Einstein, MSK, Mount Sinai, New York Hospital, Columbia, Cornell. They all have clinical trials, and some of them are with targeted agents. And sometimes, if you find a specific mutation, someone may be a great candidate for one of those targeted trials. And again, usually we don't, but sometimes we do, and that can be very, very beneficial. So it's important to understand, the scientific and medical reasons and the commercial reasons, because someone is making money off of these tests. So precision medicine, where we match the right drug for the right patient all the time, is probably overambitious. What we really want to do is stratify patients, do molecular stratification, where we can find the right groups of patients to treat with the right types of drugs. We have to consider cost, toxicity, efficacy, all sorts of things, and we have a lot of techniques that can be very useful for cancer discovery. Okay, so switching over to just a story of a rare tumor, because it illustrates what we want to do with precision medicine. And so here was a rare tumor called small cell carcinoma of the ovary, hypercalcemic type. It was discovered by a pathologist from Boston, Bob Scully, in 1982. He passed away about a year or two ago. He was a very famous and excellent pathologist, contributed a lot to our field. And he discovered this tumor that affected young women in their late teens, 20s, and early 30s. It was extremely aggressive. If it spread beyond the ovary, it was uniformly fatal, and it was very rare. We happened to see 2 cases at our center where I used to work up the street within a 6-month period, and we said we should study this disease and use our advanced, sophisticated techniques and see what we can learn about it. And in fact, we found all the tumors at our center. It was only 3. We sequenced these 3 tumors, and my colleague called me and said, I have good news and bad news. The bad news is I should have called you 3 months ago to give you the results. The good news is that all 3 of the tumors had the exact same mutation in the exact same gene. And when you find the same mutation in the same gene in a rare tumor, it's likely to be the gene that's driving the tumor to develop. And in fact, it was in a gene called SMARCA4. We actually reached out to the patient community across the country through a Yahoo group, and we said we need more tumors to confirm our discovery. We got 9 more tumors from people all over the country. Since that time, we've gotten tumors from all over the world. We have a tumor from Slovenia, one from England, one from North Carolina, which is part of the United States. But once you're outside New York, it's like the rest of the world. Anyway, we got 12 tumors, and all 12 tumors had exactly the same gene that had a mutation. And the other remarkable thing is there were no other mutations in any of their genes. So just for example, the typical cancer has 50 to 100 mutations. Some have thousands, pediatric tumors have only a handful, but most have 50 or 100. This was an example of a tumor that only had 1 mutation, and it had none of those copy number alterations that I was talking about. So it was quite remarkable. We published this. 2 other groups published at the same time, so we all kind of confirmed each other's work, and now we're all having a conference call next week to see, again, how we can work together, part of team science. Here's just some scientific examples of how we can look at the actual proteins. This is called a Western blot. This is regular ovarian cancer, high-grade ovarian cancer, and you can see that this protein is present by this dark band over here. And here you can see 2 of our tumors where it's absent. We can also stain it with something called immunohistochemistry, and it's also absent there. In fact, we did notice in our study that 1 patient had inherited this mutation from their parents, and one of the other groups that published the same findings started their collection from a cancer genetics clinic, and they actually had about 40% of their patients that had the inherited form of this disease. And so now, because of this data, we recommend that everyone has genetic testing if they have this particular tumor type. We don't exactly know what the frequency is of this particular tumor type. I think it's probably 10 to 20%, but we'll have to get larger numbers to figure that out. This, by the way, is an example of what we call last generation sequencing or first generation sequencing or Sanger sequencing. Interestingly discovered by Fred Sanger in the UK in 1972, one of only 3 people to ever win the Nobel Prize twice in the same field. Here it was chemistry. And what you can see, this is called an electropherogram, and each of these colorful peaks is a nucleotide. And in here, there's supposed to be 1 at each location, but here you can see 2, and that's a mutation. So one of the nucleotides that was supposed to be there got altered, and now you see 2 nucleotides, and so obviously 1 normal nucleotide on 1 copy of the gene, and 1 abnormal or mistaken nucleotide on the other copy of the gene, and that's causing the cancer, because it just happened at the right gene, or the wrong gene, the right gene at the wrong time, and that developed the cancer in some particular tissue, probably the ovary. This type of sequencing is very limited because, as you can see, we have 1 pretty sequence, and it's not always as pretty. Of course, I'm showing you the prettiest one, or else I wouldn't be showing it here. But this is a pretty sequence, but it's very hard. It doesn't always look like this. This on the left side is next generation sequencing that you may have heard of. And so in next generation sequencing, we can sequence a population of DNA 100 or 1,000 times. On the right side, the Sanger sequencing, we only can sequence the population once or twice, and therefore we miss things. But by doing next generation sequencing and sequencing a population of DNA that came from a tumor 100 or 1,000 times, we can find mutations that are present in a very low frequency that we would miss with the other type of sequencing. And this has been revolutionary, and in the past 5 years, it's become quite common. 10 years ago, it was being developed. Now, all of the genetic testing typically uses next-generation sequencing. We're now doing it in our own laboratory, and it's really great because we can find things that we would have totally missed, and the data that we find is very reliable. And here, basically, you can see in this patient who had the inherited mutation that in what's called their germline or their normal tissue, you can see this T, which is the abnormal nucleotide, and the normal nucleotide's not shown. And then the tumor, the abnormal nucleotide has completely taken over the tumor sequence, and that's called homozygous in the tumor, and that's what's causing the disease. Let's see. So we've done some growth studies to show that we can replace this gene and cause the tumors to slow down. We've put it into some mice, and we can do the same thing, showing that this is an important gene. I'm going to skip that for now. This, by the way, is kind of what I think we finished lunch pretty much, right? Okay, so this is a mouse. This, you can actually see a tumor that we've actually grown inside the mouse. We can study the tumor. We can feed the mouse drugs, and this is how we do all sorts of drug development by using mouse models. Now we can actually take individual people's tumors and put them directly into a mouse, and so now we have a better representation of human disease. But the cool thing is that because of this gene being lost, another protein becomes dependent, the tumor becomes dependent on another protein for the tumor to survive. And so we don't want the tumor to survive. We want the person to survive. We don't want the tumor to survive. And the tumor is dependent on another protein. And it just so happens a company had a drug that targets this protein. And because we now know that this type of disease is driven by this mutation and it needs this other protein to survive, and there's a drug, we can put it all together, and that was actually done in what's called a phase 1 trial or early stage clinical trial where this drug was given to humans for the first time. And it just so happens on this trial, 2 patients had this very rare tumor called small cell carcinoma of the ovary, which is sometimes called malignant rhabdoid tumor because of the way the cells look. And in fact, these 2 patients with this rare tumor type had some of the best responses. This is called a waterfall plot. I think Dr. Jazari might have shown some of these plots this morning, these graphs. And in fact, these 2 black bars mean the tumor is shrinking, and that happened in these 2 specific tumors. And because of that, here's an example of a large tumor mass that got smaller after only 16 weeks of treatment. That's great. And because of that, we now have what's called a phase 2 trial, where the trial is specifically geared towards women with this rare disease and a few other types of cancers that have a similar molecular defect. And this is kind of the dream of what we're trying to do with precision medicine, is find the target, make the discovery, find a drug, make a drug, or repurpose a drug, which was what's done here, and use that drug in clinical trials. And this is ongoing now. It's open at a number of centers throughout the country and throughout the rest of the world. And a number of our patients with this rare tumor are going to be enrolling on the trial. And this is an example of what we call a basket trial. And this is kind of another buzzword, along with genomic medicine and molecular profiling, are basket trials. And basically, we're looking at the molecular defect in the tumor, and we're matching the clinical trial to patients who have that molecular defect. And we don't care what kind of tumor they have. So we're agnostic to disease type. We don't care if it's ovarian cancer or some rare sarcoma. In this case, it's a special type of kidney cancer, a special type of ovarian cancer, and some rare sarcomas that occur in very rare parts of the body. And all of those tumor types have the same defect, and they all can go onto the same trial as a basket. And they're put into baskets. There's a basket for the ovarian cancers, there's a basket for the kidney cancers, there's a basket for the sarcomas, but they're all getting the same drug. And we'll figure out for which basket is the drug the most effective. And there's other basket trials. You might have what you heard about this morning, a checkpoint inhibitor. You might have a checkpoint inhibitor trial where there's an ovarian cancer basket, an endometrial cancer basket, and maybe some other type of basket. And these are what we call basket trials, and it's great because we can use the same drug and the same clinical trial to try to treat a much larger portion of our patient population. And so I think I'll probably wrap up a little bit with just a overview of ovarian cancer, sort of doing this a little backwards, but I didn't want to short shrift the rare tumor. And I don't know if you heard a lot, I don't think you heard a lot about this morning, but just to make sure we're all on the same page, because this page is a very important page, and that is that ovarian cancer is not one disease. It's many diseases that occupy the ovary, and they're as different as breast cancer and lung cancer. You would never say that I have a chest cancer. You would say I have breast cancer and lung cancer. We know they're very different. We know they're caused by there's different causes, smoking versus other causes. Same with ovarian cancer. There's different types of ovarian cancer, and they come from different places. And this is just a pie chart showing you the different types. The most common and the most aggressive is high-grade serous carcinoma, or what we used to call high-grade serous ovarian carcinoma. We've sort of dropped the ovarian for reasons that I'll come to on the next slide, which I don't think was discussed this morning, but not completely sure. So high-grade serous carcinoma, I call this regular ovarian cancer. It's what you read about in the papers. It's what many people may have had or experienced. It's aggressive. It usually presents at an advanced stage because we don't have very good screening tests as of today, but we're working on them. That's the most common. The next two most common types are endometrioid carcinoma and clear cell carcinoma. Again, less common, less aggressive, because they usually present at a much earlier stage where the cure rates are much higher and the treatments are more successful. And the reason is this, and I'll go back to those slides in a second, but the reason is that they come from different places. So ovarian cancer, high-grade serous ovarian cancer, begins at the end of the fallopian tube. Endometrioid and clear cell carcinoma begin in what's called endometriosis, which originally came from the uterus, the line of the uterus called the endometrium. So in some theoretical world, we don't actually have any ovarian cancer. We have fallopian tube cancer, and in the theoretical world, we don't have any ovarian cancer. We have fallopian tube cancer and endometrial cancer. And I'm a little bit, not joking, but I'm a little bit theoretical because they're all called ovarian cancer, and they really are ovarian cancers. But the actual cell where they developed from, 10 or 20 years before that cell turned into a cancer, that cell was born from either the fallopian tube or the inside of the uterus in most cases. And so they've occupied the ovary. The ovary is very important. It lets the cancer cells grow. They may have turned into cancer on the ovary. But when they were born, they actually were born from either the fallopian tube or cells that came from the uterus originally. And those cells landed on the ovary. All those cells landed on the ovary and turned into ovarian cancer. So it's still ovarian cancer. It looks like ovarian cancer, but now we know where they came from, which means we have a whole new arena for cancer prevention and screening. And in fact, this was a very important part of the Institute of Medicine report, which was issued in March of this year. It's freely available online at the website. You can look here. You can search IOM ovarian cancer. But basically, the Institute of Medicine was tasked by the Centers for Disease Control that was tasked by the Congress to look into the unmet research needs in ovarian cancer. They published this many 100-page report, and one of the themes was that ovarian cancer is not one disease. And by treating it as one disease, we're basically doing the same as treating breast cancer and lung cancer as one disease, which no one would ever think about doing. But this is a relatively new concept. Those in the field have been familiar with this concept for 5 or 10 years, but the rest of the community, whether it's doctors or patients and even scientists, were not aware of the distinction of all these types of ovarian cancers. And so when you're a scientist in a laboratory studying ovarian cancer and you lump all these things together, you're going to find confusing results because you're studying breast cancer and lung cancer. And so we actually called this title Ovarian Cancers. And we sent it to the copy editor. They said, excuse me, I think you made a mistake. There's an S. And we said, no, we meant for it to be plural because it's not one disease. It's many diseases. We do prioritize high-grade serous carcinoma because it's the most common and most aggressive, but the other important message is that we have to be doing subtype-specific research, and you may have to say to your doctor, what type of ovarian cancer do I have? Do I have high-grade serous ovarian cancer, or do I maybe have clear cell or endometrioid cancer? And that may affect many things. And so just to finish up, just to say that we talked a little bit about ovarian cancer. This is a slide basically showing what I've showed you before. And so I'll skip to just let you know that we are learning a lot. We are learning about what drives these cancers. And I'll just show you on this slide that about, where's my mouse here? Okay, there we go. About 20%, about 30% of the tumors are likely related to some defect in the genes BRCA1 or 2 that you've heard about. About half of that is potentially inherited, and about half of those protein defects are caused within the tumor themselves. We have another panel of about 10%, here we go, 10% of the pie that's caused by other genes that cause defects in the way DNA is repaired. Some of these are inherited, and some of these develop within the tumor themselves. We've learned about 20% of the tumors actually have a defect in something that regulates the cell cycle, and these tumors are very aggressive and hard to treat. And then we've learned about some other genetic defects. And by looking into these parts of the pie, we can now target different scientific approaches and therapies to the underlying defect in the tumor. And we're doing that. You've heard of PARP inhibitors. I don't know if anyone's talked about that today, but if you've come to these courses before, there's always a good discussion about PARP inhibitors. PARP inhibitors target a particular type of DNA damage, and they work really well in people who have BRCA mutations, and we're trying to figure out who else they're going to work really well for because it's very promising. We're trying to expand the arena of who will be eligible for PARP inhibition, and right now the treatments are restricted highly by the FDA and not the drug companies, really the FDA, and we have to figure out how to do the right trials to get these drugs earlier into patients and into more more doctors' hands to give to more women with ovarian cancer. And so just to finish up, we're trying to look at the tumors in general and figure out what defects in DNA the tumors have, and I'll just, I know I'm skipping around a little bit here, but I'll just show one slide to you that was shown at our annual clinical oncology meeting called ASCO last year, and this is basically a figure from the table, a figure from the presentation on how the responses were, and this shows what I just talked about is that women who had BRCA mutations had a very good response. Women who didn't have BRCA mutations didn't have as good of a response to this specific PARP inhibitor, but in between this reddish line in between here was people who had a DNA repair defect for reasons that we're not entirely sure of, but we could categorize the type of DNA repair defect, and they had a better response than women who had tumors which did not have this type of DNA repair response, but not quite as good as those PARP inhibitors. And so we want to study this group of people to figure out what makes some tumors respond better and some not respond better. And we're working on that with a lot of collaborators on a lot of clinical trials. And so just to sum up, nowadays the genomic landscape forms the backbone of clinical trial design, and that's good because these are intelligent trials. And nowadays, what I like to try to tell the drug companies is that if we do a big trial that you list as a failure because the response rate was very low, that's unfortunate. But if there's one person who responded, let's figure out why that one person responded, and now we'll learn more about how to do the next trial better. So we need sophisticated studies to fully understand the complexity of this disease, and the molecular profiling holds a lot of promise to improve outcomes through molecular stratification, superior subtyping, and basket studies are a good way to actually investigate the specific populations of patients and tumors that have specific molecular defects. And so with that, I just want to, again, emphasize that we are very grateful to all the support we get from so many people, including the government and our funding agencies, but most importantly, our patients, because they allow us generously to study the tumors that we take out of them. They're our partners in research. They give us lots of great advice in clinical trial design, what's tolerable, what's not tolerable. A lot of us, I'll exclude myself, but a lot of the scientists and other people have never come in contact with an ovarian cancer patient. That's very important to know that all of our efforts are really going to help somebody who we care about quite a lot. This is my laboratory. It really takes a village to do all these studies, and thanks for coming out today.